Hein Heidbuchel, Belgium. Title is EuroEco study. Please.
The EuroEco study is a health economic trial in patients with implanted ICDs, where we looked at the effect of home monitoring, remote monitoring technology on the costs. This is my disclosure slide. The disclosures of all the co-investigators can be found in the European Heart Journal Fast Track publication that will be released today. Note that my work here was done while at the University of Leuven, but my current affiliation has changed to the University of Hasselt and the Heart Center Hasselt in Belgium, and this trial was sponsored by Biotronic. The background is that remote monitoring of devices is around for about a decade or more, that all stakeholders see benefit in that sort of technology. Patients are better followed. Physicians and hospitals see an optimization of their time allocation they spend on remote follow-up, and the payers of healthcare also have a means of improving medicine, maybe even for a lower cost. The problem is that up till today, there has been no specific trial looking at the cost effects of remote monitoring on the provider itself, the hospital, the physician who has to do the work. Although it needs a reorganization of care, nurses needs to be trained and funded, and there are economic implications. So therefore, the primary endpoint of this EuroEco trial was to look at the total follow-up related cost for the providers, the hospitals and the physicians, doing implantable defibrillator follow-up, comparing remote follow-up using the home monitoring system with classical in-office visits. There are some secondary endpoints, which is looking at the total cost from the healthcare payer perspective, which has been done in some other trials, but not as extensively as in our trial. Also, the impact of home monitoring on the net income of providers and some other secondary endpoints. This is the study design. We had 312 patients implanted with a VVI or DDD ICD that was capable of home monitoring with electrogram transmission, more modern version of home monitoring, all Biotronic devices, Lumos in a couple of them, Lumax in all the other patients. 303 patients were available for analysis. They came from 17 centers, as you can see, in 6 countries throughout Europe. And we followed them and we randomized them to a classical follow-up without home monitoring and a home monitoring assisted follow-up. All patients had 3 pre-specified in-office visits after 6 weeks, after 1 year, and after 2 years. When there was no home monitoring available, other scheduled follow-up visits were left at the discretion of the investigators. With home monitoring, of course, we relied on the home monitoring data analysis. We looked at resource utilization during follow-up in the center, but also with other physician visits or hospitalizations. We tracked the time spent by physicians and nurses and technicians during each of those contexts. We developed special tools to that, and we converted that into monetary valuation by country-specific data from these different countries. These are the primary and secondary endpoints. At the top, you see the primary endpoint, which is the provider perspective, and this is data for all the patients that were followed in the trial. And in fact, here in the middle on the top, you have the primary endpoint, which is the cost for physicians and hospitals in following up patients based on classical or remote assisted follow-up, and you see that there was no difference, not in the direct medical cost, not also in the non-medical cost overhead related to personnel and space. Exactly the same cost for follow-up. Now, if you look at the secondary outcome, the payer perspective, you see that the total payer cost was also similar for patients with or without remote monitoring. There was a slight increase in other physician visits, as you could expect, but interestingly, there were shorter length of stay, not significantly so, translating into an also non-significant lower hospitalization cost. Now, if you look at what payers pay to providers, then you see here at the left upper part what the providers, the hospitals and the physicians received for the follow-up, and then at the right side here you have another secondary endpoint, which is the provider net income, and that was not different for all patients as a whole in the trial, home monitoring on or off. Now we set out a pre-specified country-dependent cost analysis in this trial, and these results provide the real insights in the trial. And as you can see here, we calculated for 5 of the 6 countries. There were only 2 patients from Finland, so we couldn't do a country analysis there. You see at the left here countries where no reimbursement is currently available for remote monitoring services. And you see that although the costs for the follow-up for the providers are the same, home monitoring on or off, they have a lower reimbursement because usually there's only fee-for-service for in-office visits, and so the net income in all these countries goes down, whereas in countries with existing reimbursement, you see that the net income is going up for the physicians and the hospitals, and this will definitely incentivize hospitals and physicians to transition their model of care, of course, to remote monitoring. And interestingly, when you look from the payer perspective, you see that in countries that do not provide home monitoring or remote monitoring reimbursement, the payer saves money. But even in countries where the payers have already provided some remote monitoring reimbursement, they do not pay more and because they have savings on the hospitalization side, as I've shown to you. So the conclusion is that when you look at the EuroEco population as a whole, provider costs are equal. I couldn't show you that we save time on physicians, but others have to spend more time, like nurses and technicians. Payer costs are not significantly different, but they tend to be lower. The country analysis shows that the provider income increases or decreases depending on available reimbursement, and that this may be a factor in incentivizing reorganization, and that payer costs did not increase, not also in the countries where reimbursement was present. So as a take-home message, I think that the EuroEco data provide objective data that can stimulate discussions in each of the countries where we can talk about proper reimbursement of this sort of technology, which has shown its benefits from a clinical standpoint in other trials for both industry, physicians and insurers, the payers of healthcare, and that this may provide patients with a more continuous care, and at the end of the road, this will make remote-based follow-up available to those, and that may be a dominant strategy, better medicine, and maybe even cheaper for society. I thank you very much.
Question, please.
Steve Stiles, theheart.org. It says that the costs of the equipment were not factored into this. Is that realistic or fair in determining the balance of costs?
Yeah. We discussed it at the outset of the trial, decided not to do that because, in fact, there's no objective way of measuring what is the cost. It's the price set by the manufacturer. So we thought, let's calculate what is the cost difference now and whether there is any margin to also compensate industry. And that's what I said at the end, that it's now up to discussions among all the parties to see how we can make sure that also the industry gets its fair share for the technology.
Would industry have a motivation for providing it free in order to sort of make it consistent with what your study shows? I mean, is there a reason for them to do it that way?
Yes, there is a reason, because of course at this moment it is part of a marketing strategy. Having the technology available makes their products more attractive, of course. but they need to not only develop the technology, there is R&D, but they also need to provide the servers that have all the information. They also take much of the communication costs on their shoulders nowadays, and you can wonder whether that is fair. So I think that is now open to discussion, and that needs to be seen.
Could you explain, again, you touched on it some, but the impact of reduced hospitalizations on the cost structure?
Yeah, so that was not significant, but what we noticed was that there was a slight decrease in hospitalizations, but mainly a decrease in the length of stay of hospitalizations. And this is an analogy with what has been seen, for instance, in the CONNECT trial. There was a significant reduction in the length of stay and a significant reduction of hospitalization costs related to that. Our trial was much smaller than the CONNECT trial, so was not powered to pick that up. But we clearly see the same trend as was significantly seen in other trials.
Okay, thank you. We would like to close this press seminar about hotlines